right, good morning. We can get started, and as other people join, they can pop in. So my name is Kimberly Lakin from the Hospital for Special Surgery and Weill Cornell Medicine in New York City. And the topic we're discussing this morning is wound care in scleroderma. And I'd really love for this to be an opportunity for you all to share if there's anything that you found to be very helpful. We are very open and happy to have a discussion as well. And I can go through some of what I have here. So as an overview, first we'll talk about the types of ulcerations in scleroderma with really a focus on the digital ulcerations we see in the setting of Raynaud. Then we'll focus on topical approaches to the wound, including some surgical options, oral options, and then some discussion about prevention. And normally when we would do this talk, we often start in the oral therapies because as a doctor, we tend to be most comfortable with talking about the medicines we're prescribing. But for this talk, actually, I figured we'd go in reverse because I think that there's a lot of questions around what are the options and what can we do at home for the wounds topically. So as you know, scleroderma affects the blood vessels, causes inflammation, and leads to thickening and scarring of the skin and other organs. And the vasculopathy, which is when the blood vessels aren't functioning quite normally, is really sort of a leading driver of ulcerations and wounds in scleroderma. And they're quite common, so up to half of people with scleroderma have a history of digital ulcers of some type, and they often occur in the early years of scleroderma, but they can occur in later time periods as well. And unfortunately, they can cause significant pain as well as disability, sometimes time off work, and they really can impact quality of life. And it's important to also recognize the digital ulcers when they're forming because they also can be a sign of internal organ involvement or at least be associated with internal organs. So some patients with digital ulcers may be somewhat at an increased likelihood of developing elevated blood pressure in the lung system or pulmonary hypertension. And so when every patient with scleroderma should be kind of staying up to date on the heart and lung screening tests, like the echocardiogram for pulmonary hypertension or pulmonary function tests for interstitial lung disease. But when we see digital ulcers, that makes it even more important to keep an eye on. And there are three types of digital ulcers that I see commonly in patients with scleroderma. So the first is what we call ischemic, which is just another word for low blood flow. So these are ulcers that occur on the tip of the finger, usually the finger pad areas. This is an area where we don't see a lot of trauma. So when we see an ulcer there, it's usually not because of something that happened in day-to-day activities. But rather, these are areas where low blood flow can occur and cause skin breakdown, which is basically what the ulcers are. But we definitely see traumatic ulcerations, and they can occur at bony prominences, so over the knuckles, for example. And those are often due to micro or small traumatic events, like bumping your hand against something. And then they also can be more common if there's a contracture of the finger where it's not fully able to extend, and those areas kind of stretch the skin and make it more susceptible to having skin breakdown or ulcers. And then often Raynaud can, if it's severe, that blood flow being reduced might make it a little bit harder for the ulcers to heal. And lastly, I'll say calcinosis is another cause of an ulceration. So calcinosis can be seen in certain kinds of scleroderma where calcium deposits are forming underneath the skin. And when they sort of try to work their way out, as the body sort of rejects the calcium, ulcerations can occur over top of those areas. And the optimal way that we manage ulcers may differ between the types of ulceration. So these are just some examples. The fingertip ulcer, kind of at the, so fingertip ulcer around the pad of the finger. We can also see these dorsal ulcerations over kind of the nail bed area. Hyperkeratosis is a fancy word for thickening of the skin. So sometimes you can see this very thickened area of skin that can occur around an ulceration. This is an example of calcinosis underneath an ulcer, and this is an example of gangrene where the blood flow is very reduced. And when I see an ulceration and I'm thinking about how to assess it, these are the types of features that the doctor or other clinical provider is taking a look at. Is there tendon exposure? How much pain is there? So pain is really important for us to get a good sense of. So if the pain is mild and has been ongoing for a similar amount of time, we can manage that. But if there's been this sudden increase of pain suddenly, often that can be a sign of infection. We look at the borders. Are they regular, irregular? The exudate, so that's the drainage. Is there a little drainage? Is there a lot? Is the drainage thick and looking like pus? That could be a sign of infection. And then we look at the bed of the lesion. So is there a sign of healthy tissue growing, or is there scar tissue that's growing? And these are some of the things that we keep an eye on. And I want to highlight in just this year, a few months ago, an update for the treating of ulcers, kind of focusing on local management. And so I'm going to review some of the findings that this paper focused on. And here first are just some overarching principles with an arch nearby as a symbol here. So all wounds, including ulcers, really should be frequently assessed and followed by experts in wound care. And so that might be a team of people that includes your rheumatologists, but also wound care specialists. Sometimes wound care nurses, for example, are really helpful. And there's a paradigm called time that I'll discuss in more detail that kind of helps us think about the ulcers in particular. The choice of dressing will be important, so we'll talk about that. When to consider debridement, which would be sort of removing the area potentially of tissue that could be more like a scab. A combination of local, sort of at the site of the wound care, as well as oral therapy is often needed in order to help with healing. We should think about large vessel disease as well, and that should be diagnosed promptly. So when we see ulcers of the fingertips and scleroderma, often those are related to the very small vessels that are spasming, typically in response to cold temperatures. But the bigger vessels that sort of start up in the higher parts of the arm or the higher parts of the leg, if those areas become smaller of those blood vessels, like due to cholesterol buildup, for example, the management would be different. And so it's important to make sure that we aren't focusing just on the small vessels, but also working with vascular if needed in order to take care of that manifestation as well. Pain management is essential and surgical intervention could be required. So let's talk about topical treatments for digital ulcers. So the principles of local wound care can be described by the term time, which is tissue for T, I is infection or inflammation, M is moisture, and E is edge. And our goal is to really remove unhealthy tissue, prevent infection, set the right moisture level, so it should be moist, not too moist, and really help the skin grow back. So when it comes to tissue management, we're looking at the bottom of the ulcer and the edges, making sure that those areas look really healthy. So like a pink kind of tissue is really common, called granulation tissue. We love to see that. Sometimes it can look like scarred, or there can be a very hard, thick layer of skin that tends to be a little less associated with good healing or quicker healing. Infection is very important to monitor for. So like I had said earlier, pain is a really good sign of infection, meaning if you sort of had a baseline amount of pain with the ulcer and then suddenly overnight you woke up, even in the middle of the night, with very severe pain, that typically might be a sign to me that there could be an infection there. And so if that's the case, I have my patients message me right away on the portal and let me know, and we think about either topical or oral antibiotics to help deal with that. Moisture balance, so we want the appropriate dressing to control excess moisture, but also to hydrate anything that's not moist enough. And then, like I said, we're looking at the wound edges and the base of the wound, and we sometimes will kind of debride, raised, or rolled edges in chronic wounds to really protect the skin around the ulceration. So like I said, we're protecting the healing tissue, edges in the bottom, and then also cleansing the wound, dressing the wound, and monitoring for infection. So when it comes to wound cleansing, unfortunately, there's really no widely accepted sort of Scleroderma protocol that has been sort of published in our community, and it's often individualized, which is why I mentioned at the beginning of this talk, if anyone has sort of their own perspectives or tips or tricks that they feel like has worked very well for them, please feel free to raise your hand and kind of jump in. But a couple of things about cleansing. So we definitely want to make sure our hands are clean before we manage the wound care. And this is really to prevent infection. And when we think about what solution we're cleaning our wounds with, usually I recommend sterile saline solution, which can be purchased. And this really keeps the ulcer clean without damaging the healthy, healing new tissue that's forming. And your doctor may have recommended other types of soaks, magnesium sulfate soaks, hypochloric acid or antiseptic solutions. These really haven't been specifically studied in scleroderma, and so kind of at a baseline, most of us are recommending just the sterile saline solution to keep it clean. So what about wound dressing? I mentioned moisture balance is essential. So if it's too moist, the tissue can become macerated and it might be sort of a breeding area for infection. So a very, very wet ulcer sometimes might be addressed with non-adhesive absorptive dressings, but too dry is probably even worse and definitely impairs healing. So dry ulcers can be rehydrated with hydrogel dressings, and sometimes hydrocolloid membranes are often recommended. Dressing changes should be done daily or on alternate days with an assessment of the wound size, and in every clinical setting, 1 to 3 weeks, depending on progression. So patients might see me, at their normal kind of frequency, maybe a little bit more often if there's an ulcer that's active, but then a wound care team who's doing another assessment as well. So again, really a team-based approach. So what about wound debridement? So this is carefully cleaning out dead or damaged tissue that can be occurring at the site of the ulceration, and that can impact the ability for the ulcer to heal. But this really should be done with caution because blood flow is already an issue, especially with severe Raynaud and then with ulcerations. And sometimes if we debride too much, it might actually kind of make things a little bit worse, and the healing of that can be challenging. But if gangrene has developed where there's really sort of more dead and damaged tissue, that kind of devitalized or dead wound tissue can contribute to inflammation and infection over time. And so sometimes we'll consider things like the scalpel approach, which is shown here, or sort of topical enzymes that can help sort of deal with some of that tissue. So monitoring for infections. So we often will recommend meta-honey, which is medical grade honey derived from plants that can help kind of sterilize the wounds and inhibit that biofilm growth, which is basically a film of bacteria, and improve healing time. But there isn't kind of big studies to support this. It's just sort of kind of a common practice. When it comes to antibiotics, I am pretty frequently prescribing topical mupirocin, Bactroban. This is a topical antibiotic, so it's dealing with kind of a broad range of the types of bacteria that potentially can infect the ulcers. I'm not really using like polysporin, neosporin so much because there are some components of those topical medications that people can sometimes be allergic to. And so sometimes people are applying it and things are getting a little bit of more red or a little bit more irritated, and it potentially could be the reason. Some centers will kind of use some silver-based dressings. That's sort of adopting approaches that we see or use in burn care, and those can be used, but there's really, again, limited evidence for sort of different approaches here that I'm describing. So this is from that review I mentioned about sort of where we're going with top local treatments, either non-surgical or surgical. So I want to talk about vitamin E gel. So this is something that has, unlike a lot of the things we do, at least a couple studies that have shown that this can be helpful in healing along with the standard of care. But the level of evidence here is basically expert opinion. So a lot of experts got into a room to write these guidelines, looked at the couple studies that have been done and said, okay, yeah, that's probably good enough. Let's recommend it. So this is based mostly on a single study that tested topical gel in addition to local standard of care. And in this study, they had a pretty regimented routine about how they were doing dressing changes and how they were looking at each of the wounds. And so, as you can imagine, even the group who didn't get the vitamin E did pretty well because they were really carefully monitored. So it may not be generalizable necessarily as far as their results, meaning that without kind of coming in frequently, having this kind of protocol outlined and really being monitored, maybe it would be a little different in sort of practice. But it's applied directly to the ulcers. So some of the things I talk about will be applied more to the bed of or the bottom of the finger. But this can be applied directly to the ulcer. There's really low concern for any systemic reactions, and the studies support that. And you can either get like a liquid formula that you can drop onto the ulcer bed, or sometimes I have patients buy the gel tablets and you can break them open and apply them there. So next I want to talk about botulinum toxin or Botox. So this is another expert opinion level of evidence, and it may be helpful in healing. There have been 5 observational studies, but really no trials. And it's a little hard to design this kind of trial. So if you wanted to have somebody come in for a procedure that wasn't Botox to, serve as sort of the comparison to Botox, like people might not want to have injections of kind of a sham Botox into them. And I totally understand that. So most of them in the studies, everyone got Botox. And this is where they inject it. So it's not over the ulcer itself, but really at the bottom, like in between. And this is sort of also where the dermatologist sometimes will do blocks if they're doing a procedure like a biopsy or something. They need to have some anesthesia at the tip of the finger. So even dermatologists maybe who aren't scleroderma specialists might be able to do something like this if they are able to kind of work with the rheumatologist and kind of discuss the approach. And it can be done in a couple fingers or all the fingers. So sometimes patients will just have one finger with ulcerations and need that one area injected, and other times, especially if the Raynaud's is severe or ulcers are happening sort of often in all the fingers, they'll do Botox in all 10 digits. And it has been in all the studies shown to be very well tolerated, but there is a common side effect that sometimes can be seen, which is a sort of temporary weakness in the hands. Not like a full-fledged, can't move your hands, but just kind of a little bit reduction in strength is what they were seeing. So we are referring patients for this in cases of sort of refractory, like you've tried everything else and it's still not working. Yes, go ahead.
Is this still a trial as far as, doing the Botox? It's been introduced to me by my rheumatologist, but she says that it's not guaranteed you'll get the medication. And I think that's why I declined it before, because I'm like, bad enough you shoot me in all my fingers.
Right.
So if I don't know whether I'm going to get the medicine or not, I don't want it.
So the question is about, whether people are able to access Botox injections outside of the clinical trial setting, where maybe there's a placebo or control arm where you're not receiving the injections. And so the answer is yes. We are at our center referring patients to our dermatologists who are able to do this. Whether the cost may be variable depending on kind of insurance. It's not necessarily guaranteed to be approved, but we've had good luck with our patients, mostly with the dermatologists at Cornell. And so we are able to offer this for people without being in the trial setting. But probably some trials would be helpful to know for sure sort of what dose, what kind of amount, Botox A or B, some of the strategies are still sort of being worked out, but we are offering this for patients. There was a trial just for Raynaud that was done that didn't show much benefit. So when I'm referring people for Botox, it's typically if there's ulcerations or wounds. So this is, again, an example of sort of where the Botox is injected between the finger webs. And this is an example of a patient who had a good response. So at the beginning of the trial baseline, there was an ulcer here. 4 weeks later, really nice improvement. Of course, in the trials, they picked the best pictures to show that they worked. But you can see that there was a really nice healing. And then this study used different doses. And then kind of said, the kind of higher dose did a bit better than sort of the smaller dose that they tried. And then no treatment, nobody who didn't get any treatment over that course of 16 weeks got better. Okay, what about topical phosphodiesterase inhibitors? And so we prescribe these a lot orally. So think about sildenafil or tadalafil. Those are really nice medications by mouth for Raynaud and digital ulcers. In some cases, people can't tolerate it. So those medications are generally well tolerated. Sometimes people have maybe some vision changes. They failed as high blood pressure medicines in a clinical trial. Meaning that in the big study for cardiovascular disease, they didn't help with blood pressure enough to be marketed for blood pressure, but in some patients with very low blood pressure, even a kind of small little decrease that people can have potentially can impact whether they can take it by mouth. So in people who can't take it by mouth, sometimes we think about the topical version of tadalafil, which is Cialis. And it can be given twice a day, again, in the web spaces of the ulcer finger, so the adjacent fingers, and we really avoid applying it directly to the ulcer. So vitamin E, we're putting on the ulcer, it's bringing antioxidants, helping with healing, but these are more basically stimulating blood flow, so you really want to kind of go downstream of the blood vessel, that artery that's supplying the blood flow, and keep it open at the bottom of the finger so all the blood flow kind of rushes to the rest of the finger. If you put it on the ulcer itself, you're really sort of missing those blood vessels that we need to open up. And again, there's kind of limited evidence for this. And so when I use it, it's for people who really are not tolerating the oral version. And there's limited evidence to show that it's really as effective as the oral option. So in most cases, because they're so tolerated, we are using the oral version, but this is out there and something to consider. So there are a lot of other local compounds that have been suggested to help with ulcerations, but the evidence is pretty limited. So I'll go through some of the things that are out there that aren't making it into sort of an evidence-based guideline. And this is where I, again, encourage if anyone has anything that's worked great for them and they want to share their experience. The theme of the next kind of section is probably doesn't hurt, unclear if it's gonna help, and can be hard to access. So first, we've had some people asking about this light therapy or laser therapy. This is a low-level light therapy using infrared, red, and violet wavelengths. And the idea here is that the light can stimulate the area to promote wound healing with biostimulation. There may be some antibacterial properties, and it might induce some nitric oxide related release, which opens the blood vessels, which is also called vasodilation. So there was one study that did this for 8 people, and this is a picture of their process. So you're wearing goggles to protect your eyes, and then the hand goes underneath the light source. And this is done twice weekly for 3 weeks. And they showed that it was safe. So that was great. There was no adverse reactions reported during the study. And then they also found that patients and physicians sort of just saying on a scale of 1 to 10, how bad is your ulcer? How do you feel? It improved during the study. One participant did drop out due to ulcer-related concerns, and there was overall a 20% dropout total. The other 2 people dropped out because of personal reasons, so maybe it was a little hard to go in twice a week for 3 weeks to have this done. So it's out there a bit, not necessarily available, but could be something that is studied more in the future. And so this is again a picture that the study chose of a ulcer that sort of healed over the course of 8 weeks of follow-up. Okay, this is another approach that has been studied. So this one's called hydrodissection, so water-based dissection, and steroid injection. So this was based on one study of 12 patients, and basically the investigators used an ultrasound to guide a syringe into the carpal tunnel of the wrist. And basically they apply some anesthetic, aspirate sort of any extra fluid, and kind of inject some water to sort of break up and dilate that space to allow a bit more space. Sometimes in scleroderma, that area can get very tight if there's inflammation of the tendons. The median nerve lives in that space, so people can develop carpal tunnel, which can cause numbness and tingling and exacerbate pain. And so to get into this study, they were really focusing on people with scleroderma who were having a lot of hand pain. But they also looked at the digital ulcerations as another endpoint to see how it was. They did exclude people with an infection. Theoretically, injecting steroid into an area that's kind of infected might not be the best idea, and that could impair some of the healing. So their healing rate was 33%, so 1 in 3 at 2 weeks. So not amazing. There were no treatment-related complications, but isn't sort of a prime time. And this is an older study, like 2011, and I'm not aware of any sort of repeat of this study, but you might hear about it or think about it if you look. And again, the recommendation said there's just not enough evidence here. But, people are doing things like this. If you have carpal tunnel, steroid injections, so maybe we can, support that. Certainly we refer patients to hand for steroid injections not infrequently if they have carpal tunnel with sort of inflammation around the median nerve. So this is sort of supporting that from another angle. So what about extracorporeal shockwave therapy? So this was studied in one single place. And basically, they do sequences of sonic pulses delivered to the ulcer directly. And in this study, the healing rate was 41% after 4 weeks, and nobody had any adverse effects. So this is kind of therapy that's around for other things, like sometimes it's being done for certain types of tendinitis or Dupuytren's contractures. And so you might find, some expertise locally in other conditions with the sports medicine or orthopedics group. Could it be an option? Maybe, but again, really not a lot of evidence here. I'm not generally recommending it for patients, but again, no adverse reactions. So it's something that maybe is out there an option, but most of the patients on this study were also taking oral medications that could have been sort of driving some of that healing rate. So topical nitroglycerin is something that sometimes is prescribed, and it can be used at ulcers. Again, we're using this medication to open up blood vessels. So the application of it is going to be recommended at the bottom of the finger so that it opens up the bigger blood vessels and kind of pushes blood to the ulcer rather than over the ulcer itself. But I'm not using it very often. One reason is drug interactions. So sildenafil and tadalafil, the phosphodiesterase inhibitors that we are very commonly using, if used with topical nitroglycerin, can lower blood pressure in a way that can be dangerous. So if you, let's say, have some of this at home and then your Raynaud gets a bit worse and someone prescribes sildenafil, make sure I tell patients to just like throw it away so that there's no chance that there's a moment of kind of like forgetting, oh, maybe I should try this on this ulcer, and then blood pressure can be dropped. But it's also pretty messy. And, you have it on your hand. It's hard to use in a practical sense. You're sort of, touching your children or your pets, and they can also absorb this medicine. So I'm not using it often, but there are some specific cases where it can be a consideration. So what about surgical options? So the first thing I'll talk about is fat grafting, which is basically using your own body's fat. And there have been 7 studies and 1 randomized trial looking at this in ulcerations. And people did this procedure and then continued sort of a background therapy. So everyone was on their kind of oral treatments to help with healing. But it did show benefit, but the optimal technique is really not defined. So how to prepare, the area, the dose, et cetera. So there's kind of a lot to learn when it comes to this, but I think it's promising, but it requires a lot, I think, of local expertise. So the people doing this have to be comfortable with it. But this is an example from one of the recent studies looking at this, and so you can see baseline 4 weeks, 8 weeks, in 2 cases where we're seeing some really good responses to fat grafting. So digital sympathectomy is another surgical option that can be used. This is another sort of expert level opinion recommendation. When I use it, it's typically for people who have really kind of gotten to the top dose of several of the oral medications we use to help open up blood vessels. And so the way this works is that the surgeon will go in and kind of separate the nerves from the blood vessels to kind of keep that process of vasoconstriction or tightening the blood vessels in response to different stimuli kind of from happening. So one of the better studies, it was of 17 patients, 90% had improvement of pain, and all of the ulcers in the study improved. There can be some complications. So this is surgery. So you can see these are images of a 3-week post-op patient. And it does require a lot of expertise locally. You'd want somebody who's familiar with this specifically for scleroderma. And like I said, you can have some poor wound healing, and then we also monitor very closely for infection. But in my experience, patients who have this can have a pretty durable response, and it is an option. I don't know if anyone has experience or want to share, kind of jump in. I'm happy to hear. So other surgical approaches that we aren't really thinking about. So bypass surgery. So there's been some studies where surgeons will try to sort of graft extra blood vessels sort of around blood vessels that are already there in order to try to kind of duplicate blood flow and make things a little bit more consistent. But that really hasn't been shown to be so helpful. And then artery release procedure, where they sort of go in and sort of release sort of tight tissue that can be seen around the small arteries to help them open, is something that's sort of more experimental. But like you can see fibrosis or thickening of the skin, that kind of fibrosis process can happen around blood vessels and make them narrow. And that process can be separate from the process of Raynaud, where the blood vessels themselves are kind of normal in diameter when they're warm, and then kind of spasm and get tight when you're cold. So in this case, sometimes the blood vessels themselves might be kind of compressed by some of the fibrosis happening. So I'd like to talk about some oral treatment options for digital ulcers as well. Like I said, usually this talk would go in reverse because this is what we're sort of used to the most kind of focusing on as a doctor, prescribing medicines. But it's just one piece. So really when, this is a paper that's kind of talked about the multiple steps and they say, oh, step 1 is the blood flow, step 2 is the pain, and step 3 is local wound care. But I don't know that I think of them as separate kind of ordered steps. I think everything needs to be taken care of together. But we'll talk about improving blood flow and controlling Raynaud, which is RP, Raynaud phenomenon, in the next section. So if you have the ulcerations that are on the fingertips, one of the reasons is that blood flow is reduced. And over time, if that continues to happen or the Raynaud attacks are long, you can develop ulcerations. And so one of the first medications we reach for is going to be the calcium channel blockers. So these are medications like nifedipine and amlodipine. They are approved for blood pressure, and a lot of people are on them for their blood pressure who don't have scleroderma, who just have high blood pressure. And so in people who have normal blood pressure, we still use it, but in people who have low blood pressure, we're going to be very cautious if we do use it. So for example, nifedipine in someone with high blood pressure, we might start at 5. In somebody with low blood pressure, we might start at a half dose, like 2.5 milligrams. And so if I'm starting at 2.5 for patients, it might not work because it's at a dose that's a bit lower than what we would typically want to use, but we start low because we don't want people to have side effects. And so I usually tell my patients, we're going to start at a low dose, and if it doesn't work, it's not because it doesn't work at all. It just means that we need to adjust the dose. So in a week, I want you to let me know, is it working and are you having side effects? What's your blood pressure? And if you have no side effects and it's not working, we're just going to increase the dose. If you have side effects and it's not working, we will definitely stop it. And depending on the side effect, we can talk more about it. But again, we're just going to increase it up. And so the maximum dose is 10. So if you start at 2.5, you have multiple steps that you can take towards 10 milligrams of amlodipine, for example. And the side effects that we can see are really dose dependent. So at the lower dose, we see a lot less side effects. At the higher doses, we see them more often. So these are things like headache, some swelling around the lower extremities, like around the ankles, and constipation. So again, these are more common at 10 milligrams. People tend to do pretty well at lower doses. But again, we're gonna make it an individual thing. Some people just need less, some people need more. Some of the side effects kind of go away over time, and so we can kind of talk about that. But what these do is they prevent the blood vessel from spasming. They keep it nice and open, so it diameter stays wide. So if you have a wider diameter, the pressure is lower, so that's why it works for blood pressure. So phosphodiesterase 5 inhibitors, so this is like sildenafil and tadalafil, Viagra and Cialis are their brand names. They are typically considered second line after calcium channel blockers. I'll consider them first in somebody who has low blood pressure. So these are medicines that kind of failed at blood pressure. Sildenafil was obviously remarketed for a bigger purpose at some point when they failed that study. And so we don't think of them as big blood pressure meds. So I do use them in people who have borderline blood pressure. But some people do see a little bit drop in blood pressure. So we start, again, very low doses and we increase slowly. And so if you started at a low dose and it doesn't work, don't give up. Talk to your doctor, adjust the dose, and kind of get it to what works for you if it does. Sometimes people have headaches, sometimes blurry vision. Of course, if you have side effects like that, let your doctor know. But these work very well for Raynaud, and they can help with digital ulcer management as well, also by increasing blood flow to the fingers. Some of these medications can be expensive. Sometimes we have prolonged battles with the insurance company, and we have letters that we send back and forth with them. But lately I've had a lot of success with the pharmacy cost plus, which is sort of like GoodRx and a drug delivery company coming together. So I see that often we can get these medications even outside the insurance company at much, much cheaper prices. So this was kind of an example of looking at the cost of sildenafil, where Cost Plus was offering something like under $5. So if you were doctors having trouble getting it for you, or if you're filling it at CVS and it's expensive, I would talk to your doctor about sort of the Cost Plus pharmacy or looking at GoodRx as sort of alternative ways to get access to these medications. It's been kind of helpful at removing some of the delays, I think. And when you have a digital ulcer, we hate delays. So if things are getting worse and you're being seen and we're going to increase or start sildenafil, we want to be able to do it as soon as possible without the back and forth from the insurance companies. So another option is bosentan. This is an oral pill for people who have recurrent ulcers despite otherwise managed, optimized therapies. So basically in the study, people were on other things, so it's not really used alone, though it theoretically could be tried in that way. In the study, it didn't help the ulcers heal faster, but it seemed to prevent new ulcers from forming. So in people who are having recurrent ulcerations, sometimes we are using this. But usually it's been kind of in part of the treatment algorithm for pulmonary hypertension. So sometimes people are on that for their heart. But we do also consider it in people who have sort of severe frequent ulcerations. So that reduction rate was about 30% compared to the placebo in this study. But again, didn't improve healing, and then it didn't help with pain of the ulcers or disability related to the ulcers. So an option, but not required if you've had a couple ulcers and your doctor hasn't given it. It kind of has medium help. So a couple other things that might help a little. Statins, so this is cholesterol medicine like atorvastatin, Lipitor, rosuvastatin, Crestor. So these are used all the time, very commonly in people with high cholesterol, but they also have an anti-inflammatory effect on the blood vessel wall, and can offer some protection. So in people who don't have a reason not to be on them, who are having recurrent ulcerations, or one ulcer that's been very severe, we will definitely consider adding it. There was a small in cardiology, 84 patients, but it's probably pretty big in rheumatology, that people on the statins seem to get fewer ulcers. One fewer ulcer is the number. So sometimes people can have side effects of these medicines, muscle aches, sometimes elevation in liver enzyme tests. So these are things to be watchful of, but it could be an option to consider sort of as an add-on. Another option as an add-on is a low dose or baby aspirin. The benefit is really uncertain, but in patients that have had one or more ulcerations who have no reason not to be on an aspirin, I am using it. So if there's a history of GI bleeding from GAVE or something along those lines, because there is an increased risk of bleeding with aspirin, though it's mild, most of the bleeding events are just kind of minor, like nose bleeding or with toothbrushing or things like that. But at the baby dose, it's pretty minor. But this is something that can potentially just help with the blood flow to the ulcer and keep things a little bit better perfused and healing a bit better. And I just wanted to note, aspirin is an antiplatelet medicine, but in some cases people will ask about the use of anticoagulation. So that's really much, much more risk of bleeding. There's really no role here for digital ulcers that we know of. Iloprost is used a lot in Europe. It's approved there and it's part of the European guidelines. Unfortunately, we don't really have easy access to this in the United States. They very, very recently, there used to just be an inhaled version, and they very recently approved Iloprost for frostbite. But it really isn't an option that we can easily access for patients in the United States. There is another kind of cousin of Iloprost, treprostinil, that is used for pulmonary hypertension. And, at our center, sometimes rarely when there's a really sort of severe case of low blood flow to the finger, we'll try this. It typically requires admission to the hospital and ICU setting. So even though it's safe and used outpatient in other countries, it is hard to access here. It tends to be hard to access here. But there are cases where we can try to make it work in certain scenarios. But if you kind of see more about it, or you're kind of wondering, like, why hasn't this been part of my regimen? The reason in the United States really has been mostly access-based. So this EULAR guideline finally, came out in 2024. There are no American College of Rheumatology guidelines for the treatment of digital ulcers, but this is just kind of a visual summarization of what I talked about. So again, the first medication we consider is the calcium channel blockers, which are the nifedipine and amlodipine medications. If there's no improvement or we're getting digital ulcerations, we're kind of going to be quickly adding sildenafil or tadalafil to the regimen. This is just to show, again, this is a much more common, the iloprost is much more commonly mentioned in European guidelines. And then bosentan is something to consider for prevention of new ulcers, keeping in mind it's not going to likely help, based on the study, the ulcers that are there on the day that you get accessed. So I want to talk about prevention strategies as well, because while we have ulcers and we need to treat them, the best way to kind of address ulcers is to try to avoid getting them in the first place. And so the first step is staying warm. And it may seem very obvious, and I'll give sort of the tips that I share with people that when I speak about this, but most likely most people as humans have found really good strategies to stay warm. But I'll tell you that, a 60-degree spring day can be as bad as a 20-degree winter day if we're not layering. And so core temperature warmth, like jackets and scarves, even when it's sort of a mild springtime day, can really be helpful. We think a lot about putting gloves on hands, but keeping warm with hats and scarves and layers can actually be very helpful. And so this includes, inside as well, the AC unit, the freezer aisle. These are things that are all year round. I generally recommend people get or consider getting kind of a big box of Costco hot hands, put them in different jackets, Amazon, whatever. I have no brand affiliations for bulk purchasing of these products, but have them easily accessible so that you can kind of shake, activate, and hold, and that can be helpful for sort of a kind of a Raynaud's attack on the go. But if you don't like the idea of throwing away things, it feels wasteful, they do make rechargeable hand warmers that you can connect to USB and charge them up. They also make rechargeable gloves. Some of them look kind of big and bulky, but they also have kind of cute, slimmer brands as well that my patients are always kind of bringing to my attention. That can be good. So staying warm, and then ask for accommodations at work if you are having an AC unit right by you. I've heard of people requesting that their vent be closed by their office, request a space heater, request other kind of accommodations. I'll write letters for anything if it would help them at their place of work. So keep that in mind too. Smoking cessation is so important. It's less and less common, which is amazing. Fewer and fewer people that I see are active tobacco users, but the nicotine in cigarettes really cause constriction of the blood vessels, and stopping smoking is going to be good for your lungs and for your cancer risk and a million other things. But for Raynaud and for digital ulcers, it is absolutely essential. If there's ulcerations, definitely think about adequate nutrition, so protein intake, things like that. There's no specific diet that you need to kind of follow to heal your ulcer, but just making sure that you're eating a balanced diet, that you are eating, including protein. All of those things will be really helpful for wound healing. We also think about trauma avoidance and protecting hands during certain chores. So if there are certain activities that, frequently cause cuts of the fingers, et cetera, thinking about ways to, have some help or to protect your hands during those activities, maybe wearing certain gloves or something along those lines. Skin hydration is really important. So when the skin is not hydrated, it's just naturally going to crack. So we see that in wintertime, people having more little cuts and things on their hands, just hydration based. So moisturize. I like Aquaphor, which is messy but wonderful, especially at night. Putting it all over your hands, can be messy. It's ointment, like Vaseline's fine too. And then using other sort of cream moisturizers during the day. It can also be super helpful. And then I recommend occupational therapy very widely. Occupational therapists can help with exercises to keep the hands as mobile as possible so that we're avoiding some of the ulcers that can happen in the setting of contractures to the best of our ability. And then they also can make custom splints and devices in order to help protect the hands during certain activities. So I recommend people, really talk to the occupational therapist about the specific things that you do at home that cause problems, because as a profession, they really like to meet people where they are and provide kind of assistance for those things. So if there's a certain activity at home that's kind of been a problem, either from a pain perspective or a trauma perspective, that can be really an important, partner. So these are some of the products I mentioned for staying warm. So gloves, hats, scarves, hot hands, rechargeable gloves. I think about, we think about the treatment, we think about the oral treatments and everything like that, but nothing is done in isolation. And these are definitely strategies that can be really helpful. I was told that the rechargeable, hand warmers were like a gift of the year one time on Amazon. So these are really accessible options that can be helpful. And, we want people to do the things that they love. And so if you love doing something outside and you're, not able to go to an outdoor event that you usually go, like a sporting event for a child or something along those lines, or skiing, humans are so adaptable, and we avoid things that hurt, and that makes sense. But just be honest with your doctor about everything that's going on, what you're avoiding, and your goals. And I think finding strategies, whether it's staying warm or starting new meds, referring to occupational therapy or wound care specialist, communication is key. So another thing is it's really important to avoid vasoconstricting medications. So these are over-the-counter type medications like decongestants. So Claritin with a D, phenylephrine is in it, or Sudafed. Those medications are kind of coming out of a lot of allergy meds, but just keep in mind that D part is vasoconstrictive or blood vessel tightening, and that can make things worse. Certain diet pills, not the new injectables, but some of the sort of older ones can make things worse, or amphetamines like and ADHD medications can also kind of constrict the blood vessels. Some medications for migraines like sumatriptan or ergotamine, those can also make things a bit worse. So keep that in mind. And beta blockers can do it as well, like metoprolol. Some people are on that for their heart, and if they need it, they should be on it, but just keeping in mind that it might worsen the Raynaud. And if there's a lot of digital ulcers, we might talk to your cardiologist about other options. So in summary, wound care is really a key part in managing digital ulcerations. We combine topical treatments with oral medications together to really support healing. It's really important to watch for signs of infection, and if there's a really big increase in pain, let your doctor know right away, because it could be a sign of infection. Protect ulcers from trauma, with bandages and things, avoiding pressure, limiting cold exposure, and more research is really needed to fully understand sort of how non-medication treatments can be helpful, like specific dressings or the light therapy, fat grafting, things like that. So just one kind of summary again, what can I do? So keep your hands warm, protect your skin, be gentle when using your hands, watch wounds carefully, kind of have your doctor help you kind of get a team together to support wound care. Be consistent with your medications. Quit smoking if that's relevant. Ask about options. If the ulcers aren't healing, maybe there's another kind of dressing option or a therapy or specialist referral that could be a good part of your care. So I have 5 minutes left, but we can go over if needed. I'm happy to answer any questions at all. Yes?
Have you had any experience with a compounded prescription of sodium thiosulfate before the ulcers that actually erupt?
So I didn't talk a lot about the calcinosis ulcerations, but sometimes we're using that for calcinosis. There's a little evidence of that being helpful, so that's something to consider. Less so, and I have used it less in non-calcinosis-based ulcerations. Yes?
If you have a calcinosis, you actually have 3 in one little toe, but we only saw it because that toe was bothering me. There's no skin irritate, there's no skin breakout, but she saw them on x-ray, and the dietitian wants to go in there and basically slit my toe open and pull them all out, which so far I have not decided to do. If you know there's a calcinosis, like I have one over here, it's been there for years, it's fine. If it's not coming through the skin, is it best to just pretty much leave it alone?
Yeah, so the question is about management of calcinosis that hasn't caused an ulcer. So yeah, some areas we can just leave alone. Unfortunately, the treatment for calcinosis isn't great and mostly based on sort of like decreasing inflammation response to the calcium that's there. So in cases where they aren't causing significant pain, often we are just monitoring.
I had one here, but and this was the most frustrating. I wasn't diagnosed yet, and my primary care doctor would just look at it. It was obviously infected. It was full of green pus. I called it my exploding thumb. It made it very difficult to open file cabinets and things.
Absolutely, yeah.
They just gave me antibiotics, had no idea, didn't ever say, well, this is what it is. But I'm grateful that it's only hit one finger, so, and it's...
Yeah. Yeah, I mean, I think that one challenge that kind of speaks to is sometimes this kind of delay, sometimes in getting to, see a rheumatologist who's familiar with scleroderma. But yeah, I mean, any signs of infection like that, we definitely want to treat. And I've had patients who had an infected calcium ulcer who, we were kind of planning on a surgical approach to it, but after we completed the antibiotics, it went sort of back to being an asymptomatic thing. So we were kind of more monitoring it and considering other options in the future. There's a couple medications, but again, nothing is absolutely transformative for everyone.
The engineer in me looks at this. It seems that a calcinosis is like a bruise or something that has caused a tear in the skin below the surface that is filled with calcium. So is it, it would seem that if you go in surgically, you're now creating another wound that's potentially going to fill with calcium. So it's like, when she's talking about the spots in there going in to cut something open, is that potentially creating another risk for more calcinosis by cutting it, opening up, and creating a wound?
Yeah, I mean, I certainly have had patients have really excellent responses to a surgical approach, but often those are cases where it's pretty symptomatic. Maybe there's an ulcer, and we've really tried everything else.
Okay.
Yes?
Betadine with ulcers with calcinosis?
Yeah.
On the same patient?
Yeah, I mean, there are different wound care centers that will sort of use a different sort of antiseptic cleansing approach. For most people, I usually go with a sterile saline solution for gentle cleansing, but there are kind of no formal preferences when it comes to sort of other potential sort of cleaning approaches. But like I said, most of the time I go for the saline solution. Has that worked? Have you've been using that with success? Yeah. Yeah. So I think it's really personalized. And so sometimes people get really good response with one thing, and then you try the exact same thing with the next patient, and it just doesn't work the same way. So it's really important to, try different things for different people. Yeah.
The challenge is, it's on your finger. You want to bandage it and keep it, well, the wound moist, but the bandage dry, and then for sanitation, you have to wash your hands. So.
Yeah. I also think occupational therapy can be helpful for this specifically because they can sort of like help work around some of those issues.
Like they make waterproof bandages, but then they're too moist sometimes, right?
Right. So a lot of the bandages we use, so we definitely want to use a non-adherent bandage so that it doesn't pull, when you take it off, it's not pulling any of the kind of healing tissue. Some of those bandages are, like I've seen ones that kind of go over the finger like a little kind of glove almost, which can be helpful. And, a lot of the ones that are kind of moist on the inside have a waterproof exterior, but it can be a little bit of trial and error. Absolutely. It is a big challenge. You had a question as well?
It wasn't really a question, it was just a follow-up to what this gentleman said about opening up the skin for scleroderma. My husband had a situation where he had an ulcer on his elbow, and the doctor wanted to do a biopsy, and then that just kicked off a whole host of problems. So that's just something to keep in mind.
Yeah, definitely. There are some ulcerations in certain locations that maybe they were worried about ruling out a type of cancer that can ulcerate. So if that's the stake, sometimes we will kind of go for that direction. But of course, wound healing is an issue. So it is a balance and kind of a discussion amongst the team members involved, for sure. I'm sorry that was a bad experience. Any other thoughts, tips, questions?
Do you find that doctors are getting more educated with regards to scleroderma skin and dermatology?
I think so. We've like as a group at HSS done our grand rounds presentations with our Cornell dermatology colleagues, and there's a lot of engagement at our center between the dermatologists and rheumatologists. I even have some private practice dermatologists who've been very engaged, but I guess it probably depends a little bit. I mean, dermatology has a spectrum just like rheumatology. Like I focus in scleroderma, other people will focus in rheumatoid arthritis. A dermatologist might be more cosmetic, might be more medical. Some dermatologists are trained in medicine and dermatology, so that kind of background tends to be a good one when we're kind of thinking about who to kind of connect our patients to. But if often rheumatologists will have sort of favorite dermatologists that really sort of engage with them and partner with them for scleroderma care.
So it's really up to the scleroderma community to do the awareness upfront with all their doctors, because they may not be educated in that area. It's just presumed at first.
Right. All right. I hope everyone has a great last day of conference. It's a pleasure to speak to you all. Have a good one.